I'm very proud to introduce the Abortion Law Reform Amendment Healthcare Access Bill 2025. Abortion is healthcare. That was affirmed by this Parliament in 2019 when abortion was removed from the Crimes Act and regulated as healthcare as it should be. The Abortion Law Reform Act 2019 was hard-fought and critical reform and a necessary step to ensuring that abortion is legal and safe in New South Wales. It took many years of hard work and advocacy by so many people to finally achieve that reform, and I acknowledge that important history in seeking to update the Act today. When the Reproductive Healthcare Reform Bill passed just over 5 years ago, I was working as a GP in Wodonga, Victoria, just across the river from New South Wales. As a provider of medical abortion, I provided care for people who travelled hundreds of kilometres across Western New South Wales and the Murrumbidgee to access abortion interstate. 5 years later, too little has changed on the ground. Abortion is now legal and safe in New South Wales, but not accessible, whether because of geography, cost, or stigma. Abortion is an essential component of comprehensive reproductive health care, as affirmed by the Royal Australian and New Zealand College of Obstetricians and Gynaecologists, as well as Australia's National Women's Health Strategy. My colleagues will know that this is an issue I've pursued consistently since my election in March 2023. My very first question as a new Member of Parliament in Question Time was to ask the newly elected government what they would do to make abortion accessible in New South Wales, particularly in regional areas and in the public health system. I have heard over and over again from people who've had to travel hundreds of kilometres or pay hundreds or thousands of dollars to access private care for what's legally and medically straightforward healthcare. The Abortion Law Reform Amendment Healthcare Access Bill 2025 will improve access to abortion through 4 key changes to the Act. Firstly, Schedule 1, Clauses 1 and 2 insert a new provision to the Abortion Law Reform Act 2019 that the Minister for Health must ensure that abortion services are provided throughout the state, within a reasonable distance of residents' homes, and that information about access to abortion services is made publicly available. This is necessary to address the issue of public hospitals refusing to provide abortion services, which is the current reality we're facing in New South Wales. In recent months, there's been widespread reporting of heartbreaking stories of people being refused care at regional public hospitals. In December, New South Wales Health apologised to patients affected by limitations on abortion services at public hospitals, including in Queanbeyan and Orange. The Minister for Health intervened in these cases, and I'm grateful for this intervention. But the current legislative and regulatory framework for abortion in New South Wales allows this to keep happening. Currently, the New South Wales Health Policy Directive framework for termination of pregnancy guides the provision of abortion services in New South Wales. This framework does not require New South Wales Health to provide abortion services, only that referral pathways are in place. And in some areas, this referral pathway is to a different local health district or to private providers. This is not a healthcare system, it's a postcode lottery. Using publicly available directories, research has found that in December 2024, a majority of the state is an abortion desert, meaning the nearest known service is at least 160 kilometres away. The public largely expects that abortion services are available in public hospitals, and communities have been shocked and horrified to learn that in many they're not. A representative survey commissioned by Australian Clinicians for Choice in early 2023 found that 68% of New South Wales residents believe every public hospital delivering women's health services should also provide abortion. There was majority support for greater access to abortion services among voters for both Labor and the Coalition. While there is an opportunity to address this issue through service agreements with local health districts, whether abortion services are provided in the public health system should not be up to the Minister of the day. This responsibility should be legislated to make clear that abortion is part of comprehensive reproductive health care. Communities would never accept that hospitals could opt out of providing access to cancer care or dialysis, or that any other essential health service could be provided entirely through primary care in non-government organisations. Especially in rural and regional areas where privacy and anonymity are a particular challenge to accessing specialised services, the local public hospital is a critical option for people to be able to access reproductive health care without stigma and without cost. In December 2023, Women's Health New South Wales wrote to the Health Minister raising that abortion costs are substantial and a financial strain for many women, and that the best way forward is to mandate that public hospitals provide access to timely and low-cost surgical abortion. Professor Kirsten Black, the chair of the Sexual and Reproductive Health Special Interest Group at the Royal Australian and New Zealand College of Obstetricians and Gynecologists, has highlighted that abortion provision at public hospitals would not only enhance equitable access, but would also support training of health practitioners. The wording of this clause is deliberately broad, so as to take into account the diversity of the state and its health services. It would not be appropriate to legislate a particular size or type of hospital or distance to services because of this diversity. What's considered a reasonable distance in Albury might not be reasonable in Gunnedah, Wilcannia, or Western Sydney. Many very small rural hospitals do not have the capability to provide surgical abortion and should not be mandated to. But many larger hospitals with the capability and staffing to do so are not providing or inconsistently providing surgical abortion. The Minister for Health may discharge the proposed duty through the Secretary of the Ministry of Health or a public health organisation as defined in the Health Services Act 1997. These provisions are to commence 1 year after the date of assent, so that local health districts are not caught out to be immediately in breach. Only 3 of the 220 public hospitals in New South Wales are routinely providing abortion and make this available publicly known. I'm aware of other public hospitals that provide abortion care either on an ad hoc basis or through pathways that are completely opaque. The clause includes that information about access to abortion services must be made publicly available. Peer-reviewed research led by Dr. Anna Noonan of the University of Sydney has demonstrated that current pathways to access abortion in rural areas are fragmented and opaque. Research published in the Journal of Rural and Remote Health in November 2024 found that in Western New South Wales, health professionals relied on their own networks to devise informal abortion access pathways. The government has invested in the SEARCH program and the Pregnancy Choices Helpline, which are worthwhile programs, but they haven't completely addressed this issue. A health worker has told me that they called that helpline in recent months regarding a patient whose pregnancy had progressed past the gestational limit for their private clinic. They waited on hold for an hour to then be told that the operator couldn't tell them which hospitals provide services and that the patient must go back to their GP, who then had to advocate for access at their local hospital. This is not the level of care that communities expect from the public health system. Schedule 1 clauses 3 to 5 expand the class of health practitioners who may perform a termination on a person who's not more than 22 weeks pregnant to include prescribed health practitioners defined as a medical practitioner and endorsed midwife, a nurse practitioner, or another registered health practitioner as prescribed by regulation. This amendment is necessary to harmonise New South Wales legislation with changes made by the Therapeutic Goods Administration in 2023, allowing appropriately qualified nurse practitioners and endorsed midwives to prescribe medical abortion up to 9 weeks gestation. This change is a clear recommendation of the statutory review of the Act by New South Wales Health that would substantially improve access to medical abortion, particularly in rural and remote New South Wales, and brings New South Wales into line with existing practice in Queensland and the ACT. This would reduce demand for surgical abortion at later gestation and reduce the need to travel for people in rural and regional New South Wales. The clause includes a regulation-making power to prescribe additional registered health practitioners to perform terminations, noting that the scope of registered health practitioners can change over time. Schedule 1 clauses 6 to 8 and 12, and Schedule 2 of the bill are consequential amendments to the expansion of health practitioners who may perform a termination. Schedule 1 clauses 7 and 8 require practitioners with a conscientious objection to refer to another practitioner who can provide the service, by removing Section 9, Part 4 of the Act, which allows practitioners to discharge this obligation by providing information. This change would align New South Wales legislation with Victoria, Queensland, and the Northern Territory. The statutory review of the Act found that current conscientious objection provisions are not always operating well. Health practitioners with a conscientious objection usually do so out of firm and genuinely held beliefs. It is their right under the Act as it stands to not be required to provide abortion themselves, but it is not the intention of these provisions that a conscientious objector can obstruct access to abortion altogether. Recent peer-reviewed research has found that a small but influential number of medical practitioners are not just refusing to provide abortion services, but also obstructing access, leaving people unable to access abortion in many parts of the state. The option for conscientious objectors to provide information rather than refer places the onus on the patient to coordinate their own care and investigate service availability. This passive approach to referral also assumes a level of health literacy and inevitably causes delay to access for what's a time-sensitive medical care. This issue has been described by Casey Haining and colleagues in a 2022 paper published in the Monash University Law Review entitled Abortion Law in Australia, Conscientious Objection and Implications for Access. Finally, Schedule 1, Clause 9 of the bill removes Section 15 of the Abortion Law Reform Act 2019. This section requires a medical practitioner who performs a termination of pregnancy to notify the Secretary within 28 days. Most submissions to the statutory review of the Act found that this section of the Act is not working well. For some practitioners who are not abortion providers, the legislated obligation creates a perceived additional risk and is a barrier to providing abortion care. While a number of abortion providers and reproductive healthcare advocates support the retention of Section 15 on the grounds that more data is required to support informed decision-making, this does not need to be legislated to be able to be collected for this purpose. There is much more work that's needed to ensure that safe and legal abortion is accessible across the state. I acknowledge that this bill, while necessary, is not a silver bullet. Cultural change within an organisation as big as a local health district takes time. Training, educating and supporting health workers takes time and resourcing, and this is not something that can be solved simply with the stroke of a pen. I understand that the Minister has asked the Ministry of Health to consult with all local health districts, non-government and private service operators and professional bodies about access to abortion care and assess options to improve equitable access and pathways to care. The Premier made a commitment in November 2024 that the public hospital network has a role to play in the provision of abortion and that this will be fully funded and the services will be available. This work is important and necessary whether or not this Parliament updates the Act. There is also important work being done to improve access to contraception, as well as fertility treatment and pregnancy, birthing and postnatal care, and care for related issues such as endometriosis and menopause. Alongside this work, there will always be a need for abortion services as part of comprehensive reproductive health care because there is no method of contraception that's 100% effective. I appreciate that for many members of Parliament, this is an issue of personal conscience. To those members, I urge you to consider the inequity caused by the status quo and the unnecessary suffering of people forced to travel long distances away from their support networks to access legal health care. I'm proud to represent the Greens who are proudly pro-choice, every MP, every vote, every time. The choice to have children or not and the choice to continue or terminate a pregnancy is one that is deeply personal. When I became a prescriber of medical abortion, I thought that it would be really hard. I anticipated grappling with ethical dilemmas that came with what I believed to be a complex and dangerous area of medicine. But it turned out that that was only because of the stigma surrounding abortion. The reality is that the medical risk from carrying a pregnancy to term is greater than the risk of abortion provided by a trained health professional. Educating and supporting my patients to exercise their right to make decisions about their own bodies as safely as possible, whether that was prescribing medical abortion, organising surgical abortion with a colleague, providing non-directive counselling or organising mental health support, or providing antenatal care for a pregnancy a patient decided to continue, was a rewarding and empowering experience. It was not an easy decision as a country doctor to give up general practice and become a politician. I made a promise to my patients when I left general practice that I would continue to care for them from the Parliament instead of the clinic. And today especially, I'm keeping that promise. In closing, I have many people to thank. The bill was drafted in consultation with the Royal Australian and New Zealand College of Obstetricians and Gynaecologists, the New South Wales Nurses and Midwives Association, Family Planning Australia, the Australian Medical Association New South Wales, and Royal Australian College of General Practitioners. And I thank them for their expertise and their collaborative and constructive engagement. I thank Dr. Vijay Roach for sharing his insight and experience. I thank Richard Herford, Deputy Parliamentary Counsel, for his advice and his patience throughout the drafting of this bill. I thank the co-sponsors of the Reproductive Healthcare Reform Bill 2019, members of the Legislative Council, Penny Sharp, Abigail Boyd and Emma Hurst, former member Trevor Khan, and members of The Other Place, Alex Greenwich, Shelley Hancock, Trish Doyle, Ryan Park, Jenny Leong, Joe Halen, Jenny Aitchinson, Felicity Wilson, Greg Piper, and former members Brad Hazard and Leslie Williams. Your collaboration across party lines 5 years ago was essential in leading to the debate we can now have about access to what has been appropriately legislated as healthcare. I thank two former members of this place. Firstly, now Senator Marine Faruqi, whose fierce advocacy put the issue of abortion decriminalisation squarely on the political agenda before the Parliament was ready to make this change. I also thank now Senator David Shoebridge, who provided valuable advice when I tried to introduce a safe access zone around Albury's abortion clinic at a local level. I thank frontline health workers, nurses and midwives, GPs, obstetricians and gynecologists, social workers and others who are doing their best in challenging circumstances to support their patients to access abortion care. I welcome and thank those here in the gallery and watching online for your support today and every day. It's powerful for every politician across the political spectrum to see and hear your support for this reform. Finally, and most importantly, I thank the generations of activists and advocates for women's rights and reproductive rights before me. My work has only been possible by standing on your shoulders. Today, we're witnessing reproductive rights under attack in the United States and closer to home in Queensland and South Australia. The best way to safeguard our hard-fought rights here in New South Wales is to embed access to abortion across the health system. I commend the Abortion Law Reform Amendment Healthcare Access Bill 2025 to the House.